Could you briefly introduce yourself, please?
Yeah, thanks for having me, Noah. So I'm Dr. Siri or Chris. I am currently an anesthesia resident over at LAC USC, and I'm currently in my third year of residency.
Okay, so we'll get to the question right away. My first question is sort of a general introduction question. What
Okay,
are the different types of anesthesia, and how do that is determine which type to use for different patients?
that's actually honestly is a pretty good question because I think a lot
Mhm.
of patients, especially out what we call outpatient surgery, which is usually you
Right.
go in the morning and you leave that same day,
Uh-huh.
are a little bit concerned as to what kind of anesthesia they're going to get. So
Mhm.
the main ones are what we call MAC, which means monitored anesthesia care, which is what you can kind of imagine of yourself if you ever had like a root canal or if you ever had to have your wisdom teeth pulled. There'd be something
Yeah.
similar. And then general anesthesia, in which you essentially would require a kind of breathing device to help you breathe. And that's a little bit more common in more, I guess, educational surgical centers or non same day surgeries.
Okay. So what MAC would be more of like a particular for specific regions, right? Instead of like, just holistic sort
Right.
of.
So Mac, it kind of depends on the type of surgery, but it's
Mhm.
for anyone who can. It's like a minor surgery, be it like cosmetic or something just like a tooth where you can give what we call local anesthetic. So if you ever had that numbing medication gun, it's very similar to that, and we can give you a little bit of medication to help you just feel nice and relaxed during the case.
Oh, I see, I see. Then what types of medications are patients not allowed to take before we can inject those type of anesthetics to patients? What are and why do those medicines kind of interrupt with the anesthetics?
That's also a good question. It's actually something that we are currently working on
Oh
and
yeah.
just trying to encourage patients to know what to take or what not to, just because it gets a little confusing as I'm not sure if you encountered that or maybe your family has, but sometimes you go to your primary doctor and it's like, oh, you have to take these medications every day, don't miss a pill.
Yeah.
And then obviously you come to either see your surgeons or you see us,
Right.
and we say, oh, can you please stop this medication for a week or a month or before? And then it gets a little confusing because you're like, well, the other doctor told me this. So I guess kind of going off of that, the main things, at least if you're coming to surgery, the things that we're most worried about is if you're taking what we call, I guess the general term is like blood thinners or anticoagulations. A lot of patients may be on warfarin, which is a blood thinner. Sometimes they had any kind of heart issues, so they may be taking baby aspirins or sometimes even Plavix, things like that. So the most important is talking to the surgeons because it does affect their ability to be able to visualize where they're operating because of the bleeding, and from our perspective too, because sometimes we can get a little bit nervous if there's too much bleeding and we may have to give the patient blood products. So that's the main thing. And then others are certain antihypertensive or high blood pressure medication. The most common one is what we call lisinopril, which is called an ACE inhibitor. And the unfortunate thing about that is actually a very effective blood pressure medication. But the unfortunate thing is that sometimes it makes our medication that we could give if the patient's blood pressure is low during the procedure less effective. So those are the two main ones, and also certain diabetic medications such as SGLT2s, which can cause potential like kidney injuries, and metformin as well. So,
Mhm.
but in general, usually, again, we're trying to work on this, but we usually try to reach out to the patient ahead of time to be able
Mhm.
to make this plan and let them know what's going on.
Okay. Then this is additional to the previous question.
Yeah.
I heard it's like a public myth. I think I heard herbs, like some types of herbs, could also interfere with the anesthetics. Is it also true?
Yeah, so that's a great, and you're not wrong about that. So St. John's wort or even like excess amounts of garlic, things like that can actually, or even licorice, things like that can actually affect the way medications work in someone's body. And so those are things that we try to avoid as well, like St. John's wort especially, or they can affect certain medications, usually not too much effect on and the medication we get from the anesthesia perspective, but they are actually, that's a good point. those supplements, I would encourage any general population to kind of talk to the
Yeah.
anesthesiologist about those.
Okay. So those herbs might work as like the three examples you mentioned before, like the anticoagulants and everything,
So
diabetes.
yeah, so it can definitely compound on top of that. By
Okay. Yeah.
themselves, they're usually okay, but it
Mhm.
can affect those medications.
Oh, I see what you mean. Okay. Then this is also a question regarding the medication. Um, but after the surgery is done, is there like a specific way to wake up the patients earlier, or do the patients usually naturally wake up? Or if
Mhm.
so, what's the process?
Yeah, so that's also another great question.
Mhm.
Usually, what we give when people think about reversals is actually if the patient received any kind of muscle relaxant, then those are we do have reversals for those because the patient wouldn't be breathing on their own or they wouldn't be able to move on their own without having that reverse. It does over time go off like kind of gets get it gets cycled through your body and gets ultimately excreted out, but there are times when you need to make sure that you can reverse it fully before the patient is able to breathe again. So that's one of the medications we do give. In terms of the other ones that people think about when they wake up from anesthesia,
Mhm.
there's no real magic medication. And I think that may be like a million or billion-dollar question if we could
Yeah.
do that where the patient instantly wakes up.
Right.
But for the most part, it is a little bit of a waiting game where we need to time it correctly for the patient to be able to kind of just wake up from anesthesia, so to speak.
Okay. Then, are there times where patients don't like wake up from the from anesthetics anesthesia?
So
Or
there definitely have been case reports, or there have been times when patients don't know that. So it's just like, as you probably already know, everybody has a different genetic makeup,
right.
and sometimes within the family they have some mutations in their genes, and which makes them susceptible to certain medications, and even the neuromuscular blockade or the paralysis medications that we talked about earlier, they can actually have a lasting effect if the patient cannot properly essentially process them within their body. And they sometimes may be unable to breathe on their own or even wake up from anesthesia from, you know, 8 hours or 10 hours. But it is less common these days, but it still can happen. And in those cases, then the patient, we would keep them on the ventilator, which is the
Yeah.
machine that helps the patient breathe. And we just kind of go from there. And they would need a workup in the future. And those are definitely one of the things that we are concerned about if we do have to take them back to surgery.
Yeah. I see. Okay. And this is, I think, was my favorite question. I think the
All right.
sixth one, which is can patients scream in the midst of the anesthesia treatment? I was because
So
I've never been in anesthesia yet, so I don't know.
yeah, so unfortunately, I would say, oh, I guess fortunately and unfortunately, me neither.
Yeah.
But from what I hear from my patients, is some of them do have dreams. I would say is most of them are pretty fleeting in the sense
Mhm.
that it's like you or I dreaming at a normal night when we wake up. Sometimes we remember it, sometimes we don't. But
Yeah.
I definitely do hear from some patients that they're like, I remember having a dream, and the last thing you were talking to me, and then I went off to like Hawaii or something.
Oh yeah.
And so it does, and it can happen.
Mhm.
But again, I don't think it's every single time or
Yeah. Right. So it really depends, I think, right?
yeah, I would definitely say so. But I think those who dream do definitely get some pretty funky dreams.
Yeah. Okay. Then my next question is like the medication question. What foods are the patients not allowed to eat before surgery?
Yeah, so that again, that's a really good question, Noah, because those questions are things that are even changing now,
Yeah.
and we're trying to update it a little bit. So traditionally, patients were told not to eat for at least 8 hours, like no solid
Yeah.
food for 8 hours. And the reason for that is because we're afraid of if there's any food particle that gets into your lungs, then that can cause you to get pneumonia and may have you to go into respiratory failure and you have to go to the ICU, which no patient really wants, and we definitely
Right.
don't want that. Um, so food for 8 hours, and then usually we talk about having nothing to drink for 2 hours, and
Mhm.
that means any clear fluid, so like coffee without cream or Gatorade, things like that. Usually we're okay with, but just I guess I don't want to muddle the waters too much. But right now there's a lot of surgery centers and a lot of academic centers who are in the talks of having patients be able to take what we call clear protein shakes, because there are studies that show that if patients have enough protein, that they actually do better in recovery rather than starving them for so long. As you can probably imagine, you and I, if we don't eat for 8 hours, we get pretty
Yeah.
cranky. But
Right.
so that's also a good question. But yeah, usually no food for 8 hours and no drinking for 2 hours.
I see. Then how do those foods interrupt with the treatment? How does that work?
Yeah. So again, the biggest concern is them what we call MPO status, which is meaning just when was the last time they ate. That again, it can work. Our biggest concern is those food particles getting into the lungs. And it doesn't necessarily affect our anesthetic so much, but just a concern for the patient's safety. That's where it really comes into play. So sometimes patients may be given a little bit of water to drink with their medications before they go back to the operating room.
Mhm.
And that's okay because it's just water and the pills. And if we need to, we can kind of suck it up through what we call an OG tube or oral gastric tube. That's
Right.
just glorified version of a tube that just goes down and sucks up your stomach.
Uh,
But yeah, in general, it's basically for the patient's safety.
okay. Okay. Then my next question is what do the physicians do when a patient is allergic to anesthesia? Is there like an alternative?
Yeah, so the scariest, well, sorry, not the scariest one, but one of the most scariest one is what we call malignant hyperthermia or MH. And that's something that usually is familial. So people in family have it. They'll be like, oh yeah, my dad or my great uncle died from anesthesia, I was told. Um, and usually those are some of the things that we think about. And if that's the case, then we just avoid those medications in general. We try not to test patients with certain allergies, but sometimes we are willing. For example, if they say that they were allergic to penicillin, there are what we call um, cross coverage, or there are similar molecules within other antibiotics that we may try to avoid. But sometimes we see that the patient actually took it in the ED or something, and they actually did okay. So in those scenarios, then we do allow the patient to take it. And we always ask, the biggest thing for, I guess, for anyone who is concerned about their allergies is that they have any throat closing, if they have difficulty breathing, or if they ever have to be hospitalized or use an EpiPen. Those
Mhm.
are definitely allergies we need to know for sure. Other allergies we can actually treat pretty well.
Mhm.
If it's a rash or itchiness, we can actually handle that. But for the most part, we try to avoid it.
Okay, so it's mostly related to the respiratory system, I think, right?
Yeah, yeah. That
Okay.
from the anesthesia perspective, that's the one we're the most afraid of.
Okay, I see. Then this is additional to that, for patients that get that has throat problems with the allergy, could that be solved with a ventilator by any chance? Or
Yeah, so the ventilator definitely will be a life-saving measure because we need to force air into their
yeah,
lungs to be able to give them to be able to deliver oxygen to them. So yes, absolutely. And
okay,
epinephrine, which is why EpiPens have become so
yeah,
important. And if it patients who do have that kind of reaction should definitely carry one around.
I see. Okay, then this is also a creepy question, I guess. Can patients wake up in the middle of the surgery? Is it
Uh,
possible?
Yeah, so I think in the past, I this is I guess a very sensitive topic for
Right.
for many people, but no, this is a great question. It is possible. I guess
Okay.
the short answer is it is possible, and luckily with today's monitoring, we have luckily a lot of great modern monitors and new ones being developed every day that help us make sure that a patient is not, so to speak, awake during surgery. And what
Mm.
that usually means for most people is that they can hear noises. That's usually the first thing that comes back
Oh,
when you wake up from anesthesia is noises, and some people may remember some of that. So
oh,
if you're under, if we go back to earlier, under MAC or just
yeah.
sedation, then of course you're likely to hear it. Sometimes you may even feel it, which is expected, but we do coach the patients through that. For
Okay.
general, people talk about feeling like they wake up frozen in their bodies, and I read stories about that. And it is, again, it is possible, but less likely these days. Usually, the medications that we're able to give even if they are awake, is usually kind of in and out and usually just auditory. But I would say, at least luckily, fortunately for me, I have yet to have a patient who has ever had that experience, but it is a concern we have for most, for I guess for that most patients have.
Okay. Okay. Um, then with all this being said, I was curious about the prospect of the study. So um, I was curious what the scientists and physicians were doing to further develop the anesthesia, further develop the study of anesthesia, and the current, especially in the current pandemic, how are scientists working to improve the drug?
That's so definitely ventilators have come into light, and I'm sure, as you know, recently for the past couple of months, it was a huge hot topic before. Ventilators, for the most part, are absolutely wonderful for anyone
Yeah.
with any kind of lung disease. And there are new, what we call modes of ventilator settings that are coming out that we are trying to test to see which ones are better or worse for others.
Mhm.
Medications are continually being tested and retested. The main thing is that their safety. A lot of medication work very, very well, but unfortunately their safety is not always the best. And so those come in and out of favor depending on what it is. So there's a lot of research going on that in terms of how we can change the medications we use. For example, as you again know, as you are going through all this, you probably have heard about the opioid epidemic, or sorry, the opioid pandemic, and how we've been trying to wean away from opioids, and that's something that we also try to do now in anesthesia. We try to give a little bit less. Before, we used to be very generous, and same with surgeons. When the patients go home, give a lot of opioids, but a lot of issues come with opioids. Not to say they are definitely the best thing we can give to fight
Yeah.
pain, but because of their side effects, it's something that we really try to avoid.
Yeah.
um, and one of the new fun things, I guess, that we're trying to do with coronavirus going on is that we've been looking into the hyperbaric chamber, which I know sounds kind of crazy. Like, whoa, like I heard that in like movies and stuff, but it is actually theoretically possible, but there are
Mhm.
issues with that themselves. So we are, I would say, slowly but surely trying to progress to see how we can use that to help patients who do have coronavirus and are not and are failing on the vents, right? Because right now that's our unfortunate our last line, our last resort is to put them on the
Yeah.
ventilator, hope they can get better. But this is another opportunity for them to deliver oxygen to their body,
Yeah.
that is not necessarily through just the ventilator setting, which is just how much oxygen we give you, or what we call PEEP, which kind of opens up your alveoli a little bit to give you let more oxygen to be able to diffuse. But
I see. Then was that type of ventilator put into practice yet?
I would say I've heard of a few hospitals that have the capabilities, but to be
Mhm.
honest, I haven't heard of anyone personally that has actually undergone that. Just because I would say that it is definitely a it is not a, how do I put this, first line therapy, and is
Yeah.
not necessarily the standard of care. But again, it
Yeah.
may be in the future. So um,
Right.
I just hear a lot of talks and theories of it. So I'm sure that actually there are case reports about it, but
Mhm.
unfortunately, me personally haven't heard too much.
I see. So it's like an alternative way, I think, if anything else doesn't work.
Yeah, like a really, really last resort, just because it's unproven and so few patients have undergone it.
Okay. So we'll have to continually work on it, I think, to develop it. So yeah.
Definitely. Maybe you could look more into it for us,
Yeah,
and
I
maybe
think so. I
you
can
can
work.
you can be the you can talk I can talk to you about how to use in the future.
Okay. Well, I think I'll go to medical school later, so I think that's my ultimate goal. But yeah. So my final question is more of a personal question. I was curious if there was any instance that you particularly remember that you were, that was memorable in your workspace, as in, yeah.
Yeah, I would say I am very, very fortunate to work in the environment that I do. I feel like that my colleagues and our support staff, the RNs, the the circulators, everyone involved, even our EVS, which is environmental services, at least that's what we call them at county, worked really hard together to make the day flow smoothly and to make it safe for the patient. And
Mhm.
I really appreciate that. And almost every day I can come home with a good story, but of course at the same time frustrating stories, be it anything that went less than perfect. But I would say one of the most memorable is we had an unfortunate um, young adult who came in with cancer. He had testicular cancer and unfortunately went undiagnosed for a while, and it has actually wrapped around his aorta, which is basically the biggest vessel
Yeah.
that
Yeah.
supplies, to the rest of the body.
Mhm.
And he needed to go under surgery, which ended up taking about 28 hours.
28.
And it was he was such a nice guy, and it was one of the few times that I actually stayed for that long. Usually we get relief at some point just so we can, recuperate and come back. But this was such an interesting, and to me it's such an important case that I actually stuck it
Yeah.
out through the whole thing, and it was really rewarding. We ended up having to give him a lot of blood products, more than I would have ever imagined,
Yeah.
because they didn't end up, like, fortunately the surgeons were amazing. They didn't end up actually nicking any part of the aorta before the vascular surgeon came in, and they ultimately had to replace part of it because
Mhm.
because of the mass. But what the beauty of it all is, after that 28-hour surgery, the patient was actually able to be extubated, meaning that he was
Right.
able to have the tube taken out, and he actually was doing really well even one day out. Of course, he ended up having to get chemo, but
Oh,
just to
yeah.
see how well he did afterwards, and all the support staff and the surgeon and my co-residents who came in between to just, give me bathroom breaks and to
Yeah.
help me out was awesome.
28
So
hours. That's
yeah,
it's
and
insane, honestly.
yeah, I would say there are probably surgeries that are even longer than that, but it is
Wow.
the the amount of teamwork that goes into that is amazing.
I see. So the cooperation is really important as well.
Oh yeah, definitely. I think in the medical world, for patients, and
Yeah.
I have even experienced it, is sometimes even any kind of miscommunication can really suck,
Yeah.
and it makes confusion for everyone. So
Yeah. And that's probably why I want to major in communication as well. Science communication, journalism, I think. That'll really help. But
yeah, I think that's a really really good idea to go to. I actually never thought about that when I went to college, but
mhm.
communication is huge, absolutely huge.
Right. So okay. That actually concludes my questionnaire. Thank you for supporting my project, and it's been a really real honor to interview you, and it really helped. And I do hope that this interview will help, will ultimately help. Kind of, I messed it up. Will ultimately help resolving the misconceptions of the public